Welcome everyone to the 12th module for today's HEOR class. We'll be starting shortly as we're still waiting for some participants to join. Hello and welcome everyone. Welcome to the last module of the Strategic Health Economics and Outcomes Research from evidence generation to real world decision making. Today is the last module of the Executive Certificate course. Over the last 12 modules, we've gone through various aspects related to HEOR, from basics to analytical concepts. For today's module, we will be covering a capstone case study and a workshop. For this, I would like to call on the entire team of Dual Sphere Consulting who have guided us throughout this executive program. Please join me in welcoming Dr. Richa Goyal, Ms. Akansha Verma, and Dr. Rajpal Singh. The stage is all yours.
Thanks, Tanvi. Hi, everyone. Welcome to the last session. And although we want to show you a few things from our side, but before that, we would like to understand, is there any query, any question, anything that you want us to cover, anything you would not have understood or you would like us to repeat from our side? Because as we said, it's very content heavy and sometimes it becomes too overwhelming. So anything, and no question is big or small, we are here to help. Okay. Anything related to meta-analysis, modeling, systematic literature reviews, artificial intelligence, how to give job interviews, job opportunities, how to upskill yourself, anything you want us to take up, please let us know. Okay. um, we don't have any questions, I believe. uh, Right. Okay. So, can you give us one question? Can you give us a basic overview on meta-analysis? Rajpal, till the time Mahendra joins, why don't you start with this?
It's metasynthesis.
Metasynthesis, sorry.
Yes.
Okay. Now the questions are coming up.
Yeah. Richa, you can answer second question.
Yeah. If you had to start your journey in HEOR today, how would you prepare yourself? What would you do? Um, Nowadays, guys, there are a lot of tools to help you. There are a lot of tutorials on systematic reviews, HEOR on YouTube. Look at those, read about the basic things. At least brush up yourself. What are the types of study designs? What are the type of analysis? What is a systematic reviews? What are PICOs? Basics of pharmacoeconomic economics, at least the cost effectiveness, budget impact, these definitions you need to know. And as we discussed in yesterday's session, a brief about basic what are large language models, what is generative AI, what and another thing, what is a global value dossier, have you written any manuscripts during your masters, what was your thesis project. At least these basic understandings a person should have. Okay.
Yeah, and to answer the third question, that is when we are working on IPD data, by what all means we can impute the missing values, and what is the preferred approach, or it depends. Basically, it depends upon case to case basis. What are the methods that you are using while doing the clinical trial analysis? You have to use the same method. So there are certain methods where we impute missing values when we are doing biostatics of the clinical trial data. The same method should be used. We generally don't differentiate or use two different methods in clinical trial calculations and IP data calculations. We try to do the similar one. Richa, one more question on Singapore. How can I get an HEOR internship in Singapore for my thesis? I actually want to develop my thesis with a HEOR consulting firm based in Singapore.
Okay, then I would suggest please reach out to them at individual level, individual capacity. There are a lot of HUR companies, consulting houses in Singapore as well. Maybe you can reach out to them on LinkedIn. If you know somebody there, it would be an added advantage. But that is the only means I can think about. If you have connects, or if you don't have, then start from LinkedIn. Make connections and then reach out to people.
Okay. We have a question on data extraction grid that I will take after a brief session on network meta-analysis.
Yeah. Hi, ma'am. To improve skills, would you please let me know how to improve computer knowledge and skills as health economist and data analytics? Which all computer courses shall I learn, like language, MS Excel? Um, so if you want to know pharmacoeconomics, as Akansha said yesterday, right? Please know about the VBA coding. That is must, and a brief knowledge about R that will help you in network meta-analysis. At least these things you should know. At least the basics, and don't spend too much money. There are a lot of free courses also available. Start with that. Why I'm saying that? Sorry, because sometimes you realize whatever courses you're taking, they are not your cup of tea, they do not interest you, and we do not have to follow the herd mentality, like my friend did this, I also have to do this. Okay, so as per your interest, you will know yourself as you progress with the course. So start with the free one, and then if you want to spend money on the course, then you can decide.
Sure, thanks, Richa. So as we have discussed in detail in two sessions on network meta-analysis or meta-analysis, there are usually three steps involved in that. First and foremost and most important step is to check for the feasibility, whether a network meta-analysis or a meta-analysis or IPD analysis, whatever we aim to do is feasible with the data that we have from the data extraction grid, is feasible or not. For doing that, we then check for the treatment effect modifiers. We compare all the treatment effect modifiers, whether there is any study which is basically an outlier in terms of patients' baseline characteristics or study design. Here we had checked above for, we had checked the study characteristics. So basically all the study designs, so if we have 18 studies which are randomized clinical trials, and we have also included non-randomized clinical trials or observational studies, and those are just two, we will have to remove them from the analysis. So all the study design should be similar. Patient population that has been taken into consideration in the individual clinical trials should be similar. We cannot say that all the clinical trials will be having the same population, but yes, it should be similar. If there are multiple trials which are done on adults and there are two specific trials which are done on pediatrics, then those studies which are on pediatric population should be removed from the analysis, or a separate analysis should be done for them. In this way, we check for the study designs that all the patient population in the study design, all the individual clinical trials should have similar baseline characteristics, like they, and we also check for the quality assessment of the studies. So when we talk about the effect modifiers, these effect modifiers are basically the baseline characteristics of the patients that are included in the individual clinical trials. Like what is the age of that population, gender, race, ethnicity, age of onset of that specific disease on which we are working on, what is the disease duration of patient. So all these factors have effect on the outcome of the treatment. So if we have patients who are having any specific disease like diabetes from last 20 years, so we had done a study on that specific patient population as compared to newly diagnosed diabetic patients, the same molecule will have different effect because of the resistance that has been developed in the patients which have the disease for a longer duration. That will be giving us the lesser response for the same dosage. That is why we just compare that what are the studies which are included, and if there is an outlier, we try to remove that. That we generally do by preparing graphs so that we can easily identify the outliers. These are also called as histograms. We also use box plots that we have discussed in the session. If you have multiple studies, if your data is spanning for a single effect modifier for more than 3 to 4 slides, then try to prepare box plots. And it can be easily prepared in Excel as well. And there are certain free available tools also for that. Then we discussed about what were the different type of outcomes. What are the binary outcomes? What are the continuous outcomes? What is the risk ratio, odds ratio? You can go through that session to have a detailed information about how these outcomes are reported. Then we prepare networks. Like you have seen, there are 4 types of networks in network meta-analysis. Go back to that. So there is a single closed loop type of networks. There are star networks. There is a connected network or a complex network. And the quality or basically the outcomes are not based upon that this type of loop is better than that. All have their own significance, and it is basically to check that whether all the studies should not be out of the network, because out of the network studies could not be included in the analysis. Then quickly we'll move to the next slide deck that we discussed on the second day. That what are the outcomes. Once you run the analysis, you can get the codes. You can do it on any of the free available tools as well. This is a forest plot. In this forest plot, this dot or this is the effect estimate. Means aripiprazole versus placebo. Aripiprazole provides more reduction of base of MADRS by 1.09 as compared to placebo. You always have these type of graphs where it favors interventions, favors comparator. Based upon the data, you can write the summary as well. Like in the second case, cariprazine versus placebo. Cariprazine offers more reduction in MADRS value by 2.4 as compared to placebo. So this is the effect estimate, and there is a 95% credible interval associated with it. If that 95% credible interval line is crossing the line of null hypothesis or null effect, it means that results are not statistically meaningful. Like in the case of cariprazine versus placebo, it is not crossing the line of null effect, means the results are statistically meaningful, or we can call it statistically significant as well. This is how we interpret a forest plot. That forest plot is based upon this league table, and all the information related, all the effect estimates are from the NMA results only. Like for the same value, aripiprazole offers better reduction by 1.09 as compared to placebo. This is how to read a league table. And to understand better in the environment that which drug is offering better response or better outcomes, we generally prepare rankograms. These rankograms are based upon the sucra values, and these sucra values also comes in the NMA results. So higher the sucra value means better the response for that molecule for that specific outcome. Like here we can see quetiapine offers the highest sucra ranking. It is ranked first, means quetiapine is the best treatment for reduction in MADRS, and followed by olanzapine, lurasidone, cariprazine, ziprasidone, and aripiprazole, and placebo being the worst drug or worst treatment for this type of outcome or disease area. These sucra values come from this type of graph to basically see how it works. There are several ranks given at the lower x-axis, whereas on y-axis it is the probability. So at the rank 1, the drug which is having the high probability of being at rank 1, it is the line which is at the top. Like this is for the green one, that is quetiapine. And similar, it comes with the value of sucra as well. For the second rank, it is the green one, means olanzapine. This is how we read a rankogram. So when you are working in HEOR, so the most important thing is that you should be able to do the feasibility assessment correct, as well as you should be able to read these graphs and prepare a summary from these. And if we quickly discuss about the summary of this outcome only, we can see this, that lurasidone was more efficacious in offering greater MADRS score reduction of 3.49 over placebo. Lurasidone was numerically better than aripiprazole, cariprazine, and ziprasidone, offering an additional MADRS score reduction from baseline dash dash dash. However, 95% credible interval crossed the line of no difference. The point estimate for lurasidone comparison with olanzapine and quetiapine favored the comparators, mean the later one, but 95% credible interval crossed the line of no difference. The sucra ranking confirms that lurasidone is most likely associated with greater improvement in MADRS score as compared to placebo, aripiprazole, cariprazine, and ziprasidone. However, it ranked third after olanzapine and quetiapine. This is a brief about network meta-analysis. Richa, is Mahendra Rai able to join? So
yes, I'm there.
Yeah.
I'm there.
So handing over to you, and
Okay.
later on we can take the questions.
Just one question, Mahendra, before you start. So there was a question on what is metasynthesis. Metasynthesis is basically the qualitative aggregation of all the evidence rather than the quantitative one that we do in meta-analysis. That is basically the difference. And you draw the insights and value propositions based on the qualitative data that you have with yourself, right? And Mahendra has joined us team, although due to other commitments he might be there only for half an hour to 45 minutes. If you have any industry related questions or where you think he can give his inputs, please feel free to ask. We will take the technical questions. I mean, all of us are here even after that. Mahendra, would you like to start by any message for all the students that who have joined us today? Anything you want to share from your experience?
No, I think, I mean, they have been part of this course for last few weeks, and I believe everybody has learned something new. I was reading some comments, and I think somebody said that I've been doing SLR for 8 years, and I still feel that I am new to a lot of things. So yeah, SLR is essentially one important component of the overall HEOR piece, but then I mean, it's just one component, and you have to do a lot of things beyond SLR. SLR is a starting point, but then now you can understand what all goes in doing a overall HEOR kind of analysis. What is overall HEOR journey for a product, and multiple things follow. Once you do SLR, then you can do meta-analysis. Then you also need to see where this evidence can be used, how it can be used to help the product get access in different markets. So I think those are the things that you can do beyond doing SLR. So as I said, SLR is a starting point, and then you have to build upon that. Richa, any questions from the current list that you want me to answer?
Okay, I'll go through the list of questions. Maybe as relevant, we can take them up. Okay. Okay. Upasana is asking, I have done PhD in microbiology. Do I have chance of job interview in evidence synthesis, HEOR, or internship is must? Mahendra, over to you for this one.
Since you're a PhD, see, the whole idea is that research bent should be there, that analytical mindset should be there. So if that is what you have learned in your PhD, I think you are eligible. So if you can research things, if you can do secondary searches, if you can analyze the data which is coming from these secondary searches, I think that is what is required. So to answer your question, yes, you are 100% eligible, and you do internship. That is additional thing, but I think in your current state also, you can definitely take up anything which is in HUR.
Another question, Mahendra, for you. This I want you to take up. Bala Murugan is asking, are there any public databases available for RWD in LMIC like India?
Yeah, so if you are talking about the databases that we have in US, so those kind of databases we are still kind of are not having in India. But if you have heard of NHDM, which is National NDHM, National Digital Health Mission, so that is one big initiative that Government of India has taken up, and they are kind of mapping all the hospitals, clinics, doctors to this register, and the data has to be contributed, and every patient will have ID, which is called Abha ID. So the patients, in India, when they move from cities, from hospitals to different hospitals, clinics to hospitals, so once their records are tagged to Abha ID, everything can be longitudinal. As of today, it's not, because once the patient changes a hospital or a doctor, that data from previous hospital probably is not linked to the current, or in case they have their records and they pass the physical records to the new hospital. I don't know how much digitalization is happening in that sense. But with Abha ID and this National Digital Health Mission, that is something which is work in progress, and probably 3 to 4 years down the line, we'll have a central register of patient records, which will be equally good as the databases that you have in West, like Komodo or Proven database, IMS database that is there. So we'll have something like that. But as of today, what we leverage is the EMRs and EHRs, which are with different hospital or hospital groups. So that is what we look as source of data. But this is again scattered and different, and the structure is different, and a lot of data integration needs to be done when we collect from different sources. So that is a challenge, but yeah, I think people are working on that, and I think we are 3 4 years away from having a centralized database. So that is the current scenario.
Thanks, Mahendra. Another question from Anirban. What factors determine whether a systematic literature review or targeted literature review should be conducted? Rajpal?
Sure, thanks. So it's basically, first of the thing is what is the requirement or what is the objective of conducting that review, whether it is for an internal purpose or for making a strategy or for checking for the disease landscape, or we are doing a data landscape studies. So for these type of objectives, we do a TLR, that is called a targeted literature review, because we want to do it quickly and with a lower budget as well. Whereas when we go for submissions, like submissions, we are submitting for the drug approval or we are submitting for the reimbursement of that drug in any geography, then a systematic literature review is required. So it's basically the objective and requirement of the outcome that that defines that whether we should conduct a targeted literature review or a systematic literature review. And if you are planning, you are in college and you are planning for an publication as well, both are accepted. It is not that you always have to conduct a systematic literature review. You can conduct a targeted literature review that will also get accepted for a publication.
So a follow-up question for you, Rajpal, since you explained meta-analysis. Rajni is asking, can you explain whether the treatment effect is significant or not based on the confidence interval with an example?
That I have shown in the
You
first
just
slide.
showed, yeah,
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 I covered
yeah,
that.
yeah, you covered that already. Yes.
So maybe the underlying principle of understanding whether the results are significant from CI. So we have something called as line of no effect, which was shown in the forest plot. And line of no effect, I mean, value can be attributed either 0 or 1. We attribute 0 when the outcomes can be negative to positive. So the CI ranges from negative to a positive value. So in that case, the line of no effect will be 0. And if the CI ranges from a negative value to the positive value, then there's no difference. If your line of no effect is at 1, and if your values kind of cross that value of 1, so the range, for example, is 0.84 to 1.2 when we compare. So that means the results are not significant. I mean, the comparison is not significant. So that's how we interpret it. So you need to understand what is the line of no effect, whether it is at 0 or whether it is at 1, and then basis that, where is the CI, what is the CI range? So that's how we interpret it.
Thanks, man.
Thanks. I think, Akansha, next one I have for you. It's basically for model adaptation. What factors do we need to take into consideration while preparing a model to use it for other regions as well?
Yes, I was answering that only. So there are different things when you as inputs, what all go into the model you have to know. The clinical data, your market shares, your epidemiological data, right? Your cost data. All these are things. Also, your treatment pathway, is it the same as it was there in your your global model? Usually, the treatment pathway is not very different, but the comparators, the drugs which are approved for a particular geography might be different for the others. So you need to actually see how the treatment is differing in your region for which you want to adapt. Second, the clinical effectiveness data, how different it is data available for your own geography? Are there studies available which gives you clinical effectiveness data related to that the drug? And then the epidemiological data, definitely, right? And then so these are and the cost data, definitely the cost data for your geography, how different adverse events or management is basically treat management is done in that particular geography. It will be different from the other geography. So you need to make your model bit flexible in such a way that the values are not hard coded, not fixed, and there should be always a placeholder available so that the other person, if the model is like you want to adapt it for other geography or you want to change or use any other input, you can use the placeholder cell rather than using the fixed cell, right? So we should always have two cells in your model for one input, one where the model where from where the values are actually going into the model, so model input cell, and the other one should be the placeholder where you can actually put the values if you want to actually adapt it for any other geography and if you find any other values. So this is the way how you can consider preparing it for other regions. Hope this answers.
Yes. Thanks, Akansha. Mahendra, for you, so we were initially giving assignments to students, but we understand their parallel commitments as well. So they will be going through tests to get the certification. However, from industry standpoint, if you can just talk about what is the definition of capstone, how we amalgamate HEOR model and report, and then after that, Akansha can just walk over through another model, which is the most tricky part. So from your experience, what kind of projects that you have dealt with, if you can just speak about that a little bit.
Oh, so my capstone project in Eversana was a very interesting one. So this came directly from the CEO, and the project was about creating a new offering for Eversana, which we are not currently offering, which we are not doing. What should that new offering be? And it can be in any space related to pharmaceuticals. Uh, so yeah, I mean, so the approach was that we started talking to several leaders within Eversana. We looked at their viewpoints that what is it that Eversana is not doing today, and what they feel is something which we are lacking. So basically, trying to understand the unmet need. So whenever you are working on a capstone project, you need to first understand what is the unmet need, what is the gap. So you start with a gap analysis. That is what we did. We spoke to different people within the organization. We tried to understand what is the gap and where do we feel that there is a gap, and we will be able to answer that gap, answer that unresolved question. So that is where you start. So we looked at different things. Can we do something more on the value insights generation, creating value for the products that pharma have, or help them commercialize the product, or even from an access perspective, what can be there, or from a patient perspective, can we do something on the patient assistant program, something that we can create. So those are the kind of capstone projects that can be built. Now, specific to HEOR, so you can obviously look at what is the unmet need from HEOR perspective, or for any country that you're looking at, and what is it that can be built which can help resolve any issues, issues. So that's the starting point, and then once you identify that unmet need, the gap, then you can start building on, and then you can involve some experts, talk to experts, try to have their viewpoint, and then try to build on that. So that is the methodology basically. And again, depending on what you have identified as unmet need, you start building on that. So that's how capstone projects are typically built on. I mean, that's my input. Please feel free to add on that.
Thanks, Mahendra. Another question for you, sir, from Ajita. Sir, what role does health economist play in hospital industry, especially in Middle East? Since you keep on traveling to Middle East and you have immense experience, and after you, maybe Akansha can also add because she also has a lot of experience in that market. So, starting with you, Mahendra.
Yeah, so from a hospital perspective, or even from a MOH perspective, Ministry of Health, so they are more keen in understanding what is the overall affordability for any product. So they do a lot of budget impact analysis for any products from a provider. So hospital basically is a provider. So from a provider perspective, whether any new product is affordable. And when you do a provider perspective, you would have learned in this series what are the kind of costs that you need to consider, because a provider probably may not be interested in indirect costs. They would more be interested in the direct costs. So you need to look at what are the direct costs involved with the comparating options that you have. So the new drug which is coming in, then existing products that they already have. So you do those kind of comparisons. So a lot of hospitals in Middle East, they want to understand that from a provider perspective, what is the affordability for a new product, and they are more interested in doing budget impact analysis. Uh, in past, we have done some cost effectiveness as well, but I think budget impact is something which a lot of hospitals and even the MOH, they ask for budget impact analysis. Akanksha, feel free to add to that.
Yes, sir, yes, absolutely. So, Ministry of Health is the regulatory body basically who is there for infusion of different therapies in the formulary, and basically there the system is that uh, Ministry of Health regulates what all treatment or drugs will be there in the formulary. So for that, budget impact is important because they want to foresee how affordable that new treatment would be in comparison to others available. So budget impact, also cost effectiveness model, is also done to actually foresee the future, like long term effects, but budget impact is definitely very important. And health economists, we what role we play is we provide those insights to them, make them understand that how these like therapies would be affordable or not be affordable, how it will be in coming future economically. So yes, this is the role. So we don't have direct input in the hospitals, but yeah, through Ministry of Health, our role come in.
Right. And just to add here, so I mean, one part is where we do this analysis, and the most important part is developing that value proposition, which they can
Yes.
understand. So health economists will understand what is coming out of these analysis that we do. But more important is the value proposition, how simply we can put that data so everybody understands. So if somebody sitting in Ministry of Health may not understand these complex analysis, but they would understand the value proposition that we build out of these analysis that we have done. So interpretation, creating that value story, keeping it very simple so that everybody understands. So that is what a health economist has to do.
Agreed, sir.
Okay. Any other question before I hand it over to Akansha? Because for the capstone or to define the unmet need, we all understand that modeling is a bit tricky part. So, Akansha, all yours. Quick overview of the model, please.
So let me first show you the cost effectiveness model. It will be mass model, but just to give you an overview how actually in real world scenario it looks like. Let me know when my screen is visible.
Yes, Akansha, we can see.
So this was a model developed for respiratory therapy, right? For treatment of a respiratory illness, and so I'll I've already told you what the process is, what are the steps. Here, I would want you to focus on how actually we, collate that, how we present that in form of a model, right? So this is the first introductory page where you'll introductory sheet on the Excel, where you will have the title of the model, the basic setting with respect to your cost effectiveness model, like what will be the cycle length. I hope you now are familiar with all these terms because we have, spent 2 sessions, 2 to 3 sessions, and in between also we have dealt with these terms very frequently. So cycle length, probabilistic flag is want to actually have the PSA or not. Then cost effectiveness threshold is your willingness to pay threshold, which is mentioned as CE threshold. So price of your drug, and because it was a respiratory disease, so forced expiratory volume is a method to actually see the status of your lungs, and this was one of the parameters in the model included. So how it was included into the model. Then on the same page we usually on the introductory page we try to actually show what all interventions, comparators, a bit about the disease, about why you want to do the analysis is all given on the introductory page. So in which all drug therapies were included into the model, it was written here, and then abbreviations. On the right side, you have the flow of your disease. Actually, the Markov flow based on which your model transition probabilities will be applied and the model will run. Okay. Then after that, usually we provide the executive summary just after the introduction. Why so? Because everybody might not be interested in seeing the inputs. Usually the client always wants to have result first and see how your results have been. So intentionally the executive summary, the results part is always presented in form of a quick snapshot of summary, which is called as executive summary. So it is provided here. Okay, and here you also provide all the model settings which you have used for your analysis, like what was your intervention, your comparator, what your time horizon was, your discount rates for cost and outcomes, then what was the source of your clinical inputs. If you have multiple publications available for your for comparison of your drugs, then maybe you can have more than one type of input. This also happens, and you want to see results from all the different, maybe let's say you have drug A and drug B, and you have 2 3 publications over that. right? And two three clinical trials. You have data from 2 3 clinical trials, and you want to see the results from all of them, rather than so you can have different options in terms of clinical effectiveness inputs. You can have the effectiveness inputs from individual trials, or you can have from pooling of the trials. Okay, so based on that, you can create different clinical inputs, and you can actually use those inputs to see how each one of them will be affecting the results, right? Then patient characteristics, how at what age you want to at what age the treatment is basically starting, what is the proportion of male and female in the model, because based on that sometimes treatment vary. Based on that, based on age, your time cycle, the time horizon, your time horizon will determine the lifetime age. So that is also important, starting age of your model, like this. Then so here the quick summary sheet, where you have discounted life years, qualities, discounted cost. Sometimes undiscounted are also provided on the same summary sheet, but here only discounted values are presented. Okay. Then after this, after you have your snapshot of results, you start with your inputs. What all input goes into the model? So patient characteristics in terms of your age, proportion of males and females, how old, what was the duration of your disease, what was the type of, like they were the disease was categorized into four types: mild, moderate, severe, and very severe disease. So what was the distribution of patients? Why do we want to have that? Now, for your Markov model, at the beginning of the year, this was actually determining that patients, how many patients were there at each health state at the beginning of the model, and based on that, transition probabilities were being applied. Okay, so this page gives you a snapshot of how the patient characteristics would be. So earlier, what I did was I showed you everything on one page. But this is how, when you're actually trying to build a model, this is how segregate your information. You're not going to provide, because for uh, not a technically sound person, it would be difficult to actually understand everything on a one in a one page. So it's always advisable to make different sheets for different inputs. Like here we have patient characteristics, and on the other sheet we have effectiveness data based on the severity of the disease, the exacerbations. We categorize the patient, and we had probability data, right? We had the how the forced expiratory volume was actually improving, how it was progressing. So we had this data based based on different severities. So we use that. So this is available. This was available. Then we have health related quality of life data, which is the utility data. So we had utility by by each stage: mild, moderate, severe, and very severe disease. So we had utility data based on your severity of disease, which was used. Then you had there was also adverse events included in the model. There was one adverse event, you had to have the utility decrement for that adverse event. So whatever utility of that adverse event is, and then we had to decrease it from your overall qualities, right? So this sheet actually gives you a snapshot of health related quality of life values, your utility values. Then resource use. To calculate cost, you need to actually know how much, what all resources are being used in management of that disease overall. Okay, how many hospital visits, how many outpatient visits, how many particular type of lab tests, what all medications, all that will come under resource use. Okay, so what unit, in what way it will be presented, like uh, in numbers, like how many visits, number of visits per year, number of tests per year, or number of tests per cycle. So based on how your cost is going into the model. If the cycle is per year, you put the resource cost monthly, sorry, annually. If it is going, if your cycle is for 1 month, then you put the resource use monthly, so that you can accordingly calculate the cost at each cycle. Okay, so this was the sheet where resource use was captured. Then next sheet was where you had where we had our unit cost of each resource. So now you can see that we have different sheets for each parameter. You resource use on one sheet, resource cost on another. After that, we have result sheet. Okay. So what happens here is, here you see there are two types of result: deterministic result and probabilistic results. So probabilistic results, we don't report actually the incremental discounted cost and qualities. This is not important, but in this model it was there. For in deterministic, you actually provide discounted qualities, discounted, undiscounted qualities and costs, and whatever your effectiveness measure is, qualities, life years. Here we had uh, exacerbations avoided as well. So we included that, not here, but in the final results. Okay, now, as I told you earlier, that usually we don't do PSA manually. We put a button like this, and if I click on this, PSA will start running based on the number of iterations we have entered into the model. Let me just show you the code for it. Uh, yes. So here the trials is 1,000. So this model was capable of running 1,000 iterations for PSA, and the loop was done. The loop was made. So once the simulation was done, it will keep on doing unless 1,000 times the values are generated. Okay, and see, we just have to now click on this, and we will have our results. But if we were doing it manually, the PSA manually, which I showed you in the earlier class, you would have to do it manually every time, and then you have to create a long list of your simulation results. Like here, this sheet is created by your by the VBA code. I have not done it. Okay, so I generated the code, I entered the code, and these are 1,000 simulations which have been generated by the PSA, and all these qualities and cost for intervention and for comparator are generated, and then based on this, your where is the plot? Yeah, here is your plot. So based on this, your ISO plot, scatter plot is formed. If you can see, this is the scatter plot. Okay. So there were multiple interventions, multiple comparators available. So you can see many other plots as well. But this is how VBA coding helps you to make your life easier. Okay, so this is the way simulations are done, and then this was PSA, and then you can have another sheet for your tornado diagram, which is done for one-way sensitivity analysis, or your deterministic analysis. So here again, on one click, you can generate the this tornado diagram based on the number of variables you have chosen to actually put into the model. So basically, on whichever variables you have, so these were the variables which I have marked because they had the name of the drugs. So I have marked them. So here there were number of the variables which we entered into the model, and the one-way sensitivity analysis gave us this results: lower ISER, upper ISER, and these have been plotted into the tornado diagram. So the most wider one has the most uh, uh, maximum influence on, affecting maximum influence on the ICERs, and we always do it. We always present the results from upside down. So the one having maximum impact, the variable having maximum impact on your intervention will be on the top, and then rest will follow. So this is the way actually a, a real model looks like. Okay, so this is the tornado. I've shown you the PSA. I've shown you the results. I think that's it. Any question here? See, I cannot show you exactly the calculations in this because then
they're confidential. We can't. Yeah.
We can't share this, but I think you have got an overall idea about. Now you can, connect the dots. So last time I showed you different inputs would all go into the model on one page, and then I actually helped you to calculate the cost and qualities and qualities, total cost and qualities, and then we calculated the ICERs. And then I told you how actually PSA is done. And today I've shown you a model, a proper model, how actually all those things are presented when you are actually doing it uh, for a client or in the real world. How do you do it? A structured way, basically. Any questions?
So as we said, generally in a capstone project, an amalgamation of all the steps are done. Basically, you have to work on client's problem statement and design your solutions accordingly. All the sessions that we have taken so far give you a fair amount of idea, because we tried to take each and every aspect from practical or industry perspective rather than doing all the theoretical work. The examples that all the speakers, the line of speakers depicted were the ones that the opportunities and challenges that we are facing throughout our years of experience. Okay, so uh, anything else you want us to cover quickly? Rest, there are first the tests that you have to give, but anything else you want us to cover, let us know.
So just to check, I mean, they are supposed to do a capstone project or they don't have to do it?
No. They are supposed to
Okay.
do the assignments, but the students expressed, Mahendra, that they have parallel commitments and they are very busy, but they have to do the tests. There are a couple of
Oh, okay,
tests
okay,
that they have to
okay,
do.
okay.
Okay.
Yeah, because I just wanted to clarify. So I gave that example of the capstone project that I did. So basically, I was part of a leadership program for 6 months, and then we were given the capstone project by our CEO
Yeah.
that we have to come up with a new offering for the company. So that was the capstone project. So basically, at the end of any learning program that you do, this is what you have learned. You have to build a project. So that's the capstone project. So for you guys, you have done a HEOR program. So if you would have done a capstone project, it would have been focused on uh, building something basis what you have learned in this entire process, number of weeks that you have spent in this journey. So what you have learned, if you can do some project out of it, and that's basically the capstone project. So mine was basis the leadership training that I got, and then I had to devise something, some new offering for the company, and yeah. So the steps can be similar, but yeah, the end objective would be different. And basis that objective, you have to devise your methodology, your results would be different. So that's what the capstone projects are about.
On top of it, if in case anyone wants to do something on their own and get it verified by us or want to show us in near future, you have our contact details. I mean, all of us, you can reach out to any one of us and we can help you in that one. And as you all know, as a part of this, we are coming up with the care program where many of you only will be there, and there we'll do a proper project with you, and as discussed, we'll come up with a publication with all of us, right? As per the as per the groups that we'll make. Okay. So Mahendra, that will form a part of the care program, and majority of them are there in the same as well.
Okay.
Okay. It will start very soon. We have shortlisted the mentors and we have shortlisted the students as well. So, as I said, there was an overwhelming response from all of you. We were very thrilled to see interest from so many people in the care program. So, it took us some time because we have to assign mentors in equal numbers of the groups as well. So, but it will be, the announcement will come very soon from Dr. Ajit's side. Don't worry. Um, Bala is asking, does raising tension between India and US Trump tariff raise in AI, there is effect on HEOR job market in India? Who would like to
This
answer
is
that?
this is an interesting question. So as of now, the tariffs are limited to, I think, manufacturing sector. So services sector is still, I think, uh, hands feet away from all these things. But you never know.
But you never
Knowing
know.
Trump, you never
Yeah.
know. And I mean, the right question here is the AI. So effect of AI on HR jobs. I mean, definitely there is an effect. So I think in initial sessions only we spoke about this. So AI is basically here to enable us, and we need to learn to live with AI. If you learn to live with AI, your job is secure. So people with AI skills will replace people without AI skills. So that is what we need to know and understand. AI is not going to take your job. People with AI skills will take your job.
This is what we discussed for 2 hours yesterday. Okay, we have to move with technology. AI is an enabler. Consider it as your team member. You assign this job to AI, and the rest is assigned by the other, for the other team members. Work that ways. But yes, learn about it.
See, AI probably is a complex thing. I'll give a very simple example. So when we were in schools, I mean, for us, computer was like something, wow, that was a wow factor for us. I think I was in class ninth or 10th when I first touched the keyboard of a computer. So for us, that was a wow thing. And again, there was an apprehension that now these computers have come and jobs will be taken away. Now everybody is working on those computers. So computers are enablers. They are not taking anybody's job. A human is required. So I think the concept of human in loop and AI in loop, you would have gone through that concept. So
Yes.
understand that concept. A human is very much required in the AI loop, and AI is very much required in the human loop. So we need to learn that, and we need to live with that.
Yeah, I mean, the best example, a computer laptop came, it was like, oh, they will replace us. But see, our jobs are with laptops. We are earning or studying with the laptop, right? We survive. We put food on the table because of the laptops and computers that we have. So, similarly, take AI also as an enabler. Any other quick question for us? Okay, then I would say thank you for the patience over the last few weeks. It was a pleasure interacting with you all. If we could even make certain lot of small difference in your thought process, or could encourage you or motivate you in your career, in your study, it we are very thankful, and it's an achievement from our side. Stay in touch. The journey starts from here. It's not an ending. We all are very easy to find people. Me, Mahendra, Akansha, Rajpal, Sharmila, we are very much there on LinkedIn or various groups, and it's the start of the journey. We'll be living together. Before Tanvi takes over, I would like Akansha, Rajpal, and Mahendra also to say thank you. Maybe Rajpal, you can start.
Yeah, thanks, Richa. Thanks, everyone. Yeah, I would like to say thanks. And if you need any help at any time point of view, or working on HEOR or any SLR, NMA or modeling project, please let us know. We will be there to help. Thank you, everyone.
Akansha.
Thank you everyone for being very patient listeners in such technical topics. Hope you got a good experience. Hope you learned something new, different, and we are there. As Richa and Rajpal said, we are there to help. Anytime you want any help, please reach out. And all the very best for your future. Uh, Look forward to maybe working with you sometime in
Yes.
future
Yes.
in the
Yes.
HEOR
Yes.
industry.
Yeah. Yeah. Mahendra, you want to add something?
Yeah, I mean, absolutely. I believe everybody would have learned something new as part of this series, and they would definitely use this learning in their careers. And as everybody has said, we all are approachable. Please feel free to reach out to us in case you need any help. If you want to do any capstone projects on your own, do SLRs, NMAs, publish them. We'll be happy to be part of that. So reach out to us, and we are happy to help. All the best to everyone, and thanks for being part of this program. Thank you all.
And we over to you.
Thank you so much, everyone. Thank you to Dr. Richa, Dr. Rajpal, Ms. Akansha, and Mahendra sir as well. With sincere appreciation, we thank all of you guys for giving your valuable time and teaching us about HEOR from basics to the end. Your contributions would be recognized by all of us once we work on different projects as well. Thank you so much. And thank you for all of the part. Thank you.
All the best for your assignments, assessments. Okay, please pass, all of you. We haven't made it very tough, and please pass, huh? No, and no cheating, no AI, no chat GPT, no nothing. Okay, do it yourself, right? I trust you guys. You will not cheat. Okay.
Everyone can also refer to the YouTube playlist, which has been uploaded. So you guys can revise and then give your exams.
Yeah, actually, it's not assignment; it's assessment. Mukul. Sorry.
Assessment.
Yeah,
Yes.
yeah. So all the best and get the certificates. Okay, do well. Okay. Thank you, everyone. Thanks, team. Thank you for the support. Bye bye. Bye
Thanks,
bye.
Thank you. Bye bye.
everyone.
Thank you.
Bye-bye.
Thanks,
Bye.
everyone. Thank
Bye-bye.
you.
Thank you.